Good afternoon, everybody. Thank you for joining us for a webinar, our first webinar to be, for 2019 to begin to target cost and utilization metrics. So this is a little bit of a new review for us. We've been focusing on quality metrics. We want to begin in this next quarter to begin to address utilization metrics. We're going to start with emergency room visits. We'll take you through a couple of steps here and give you some things to do. So just kind of a refresher for the triple aim, part of our whole process, and this will be very familiar to you, is to improve health, lower costs, and better care. And managing ED visits is one of the ways that we can begin to utilize all of the parts of the triple aim for our patients and for our clinics as well. So within CPC requirements, we have an effort called Comprehensiveness Coordination. These are all words to processes that we already have in place, but one of them is to make sure we have a comprehensive approach in primary care, being able to address patients' medical, behavioral, health-related social needs when at all possible. And our work and our processes should be big enough to include ways to reduce fragmentation of care, either between specialty providers or even between levels of service, emergency room, inpatient, primary care, home health, as well as look at ways to lower the emergency room ED visits. We know that sometimes patients use EDs as urgent care proxies when there are no urgent care services available. And part of that is because they have complex medical and social conditions sometimes. So we want to be able to look at that. This is a slide that we recently saw last week at a meeting of other CPC practices in the Tulsa area that are that we meet and discuss about every other month. I want to go over this with you. This is the utilization for ED for this ends of the second quarter of 2018. The quarter 3 report for 2018 will be coming out soon, and we'll show you that and give you some more information on that in about 2.5 weeks, 3 weeks. Let's talk about this graph. So this line shows at the bottom quarter 1 of 2016 all the way through quarter 2 of 2018, and it shows the different practices that are involved here in this project. Utica Park Clinic is the green line. Other practices, small ones and large ones, some of them are single practices here, some of them are health systems like us, and you can see the variability in the ED utilization. There are 2 lines here I want you to pay attention to. The red line, which is marked PBIP, that stands for the performance-based incentive minimum, and then the PBIP max, and that's again the maximum number. We want our performance to be within the red line and the black line, closer to the black line if possible, because as we keep ED utilization lower, we have an opportunity to keep more of the dollars paid for that performance-based incentive program from CMS. As a reminder, we've talked about this probably early in 2016. Each clinic receives $2 per member per month for a utilization metric, and we get to keep that if we do well. If we don't do well, we get to pay it back. And at the end of 2016, we had to pay back most of the utilization component to this metric. We got to keep very few dollars. So 2017 numbers will be coming out soon. We want to get a head start on 2018 to see how we can, or 2019 anyway, to see how we can begin using this information to hopefully redirect some ED utilization. Again, Utica Park Clinic, you can see it by the green line. We are below that metric. We are making gradual decreases down, which for a clinic with the size of attribution that we have is probably heading in the right direction. Okay, I'm going to switch data with you guys a little bit. Before that was CMS data for Medicare patients only in CPC. We're going to look at all clinic data now for Utica Park Clinic. We get a report every month called the Frequent Flyer Report. It looks at the past 12 months and identifies patients who have had ED visits that have been greater than 4. We've struggled with this report a little bit. Recently, we were able to get them to add the primary care provider onto this report. Usually it is the rural hospitals and the rural clinics that look at this report most frequently. I usually send it out to you guys if I see some trends there. But let's take a minute to review the report in its entirety. This is a graph showing the number of patients who have been in the emergency room more than 4 times in the last 12 months. And you can see there's a lot. So if your name is not on the bottom line, like Cushing Family Practice, you didn't have any patients that were in the emergency room more than 4 times. So that's good. So if you don't see your name on the bottom of this list, you didn't have any patients that met this criteria. And some of you, as you can see, Owasso, Claremore Family Practice, and Central have some pretty good numbers, Mingo Valley. And so we want to be able to take a look at those. This is for all payers. I want you guys just to kind of keep that in mind. So you see a lot of activity here. So how do we begin to use this data to really find the patients that we need to take care of and give some support for ED utilization? Another graph, I want to present you a view in another way. Down at the bottom of this slide, it shows the number of times a patient has been in. So going from 4 visits, 5 visits, all the way up to 34 visits in the past 12 months. We had 370 patients that had at least 4 visits in all of our Utica Park Clinic practices that we want to pay attention to. You can see it drops down to 180, 95, and then it slowly tapers off into 1 patient having 34 visits in the last 12 months. That's about 3 visits a month in the ED. So we should be very aware of who this patient is and having some interaction with them. But you can see the drop-off. So our target, if we were just looking at this, would be to try to address the patients here. There's a volume there. There may be some things to do to educate patients in that 4, 5, 6, 7, and even 8 ED visits. We're going to come back to that. I want to show you the information now by payer. So you saw all that data. We're going to look at payer. The Medicare patients, which are our CPC patients, had 284 patients in that mix. We also have some managed Medicare we want to pay attention to. There were 255 of those patients. I'm just going to zero in right now on the Medicare fee-for-service patients, that 284 patient bar. Again, dividing it by clinic, you can see that there's a lot fewer patients, and some of you have fallen off this graph. Again, if your name isn't on here, you didn't have any patients that had more than 4 visits, and you can see that drop off. Still, a couple of you are having a high number, but not as high as they were before, 42, 43, 27, 24, 18. Now, let's drill down into that next level of data, and let's look at who those patients might be. Here's 128 patients who had at least 4 visits, all the way down to 3 patients and 2 patients who have had 17 or 18 visits. We want to focus on these patients in this last section, the frequent utilizers, and see if we can figure out what's going on. We also don't want to forget this high number here, the high volume here, and begin to look at that utilization and see how do we support that. But we're going to start with the 15, the 17, and the 18-day frequent ED visits. So what we've created is a place for you to get this information by your clinic that will actually allow you to see who those patients are. So if you go out to our UPC CPC Plus Connect site, you'll find a new report under the topic Population Health Quality Metrics. It says ED Summary. It will say New. Currently it's checked out to me. I don't want you guys changing the data, but you can view it and look at it and find those patients' names. You can click into that and you'll be able to see the report. I'm going to click into that information in just a few minutes and show you some patients actually in that report. But I want to talk to you a little bit about what do we do now? What do we do now that we know who those patients are? We want to review that data. We want to find those patients who are those high ED utilizers. Your data is going to look different. Some of you are only going to have 1 or 2 patients on your listing. As you can see, there will be some of you that will have 42 or 43 patients. on this report, there is a tab for each of your clinics. You will just click into your clinic's name to be able to see who your patients are that are using the ED. We want to be able to take a look at the patients who are on that frequent flyer list. Why are they going to the emergency room? Can we look at their chronic illness, or is there a reason why? Is this a social issue? The second thing I want you to take a look at as you're reviewing the charts of those patients is, were we able to make their TOC call? Were we able to talk to them and get some information from them? If you're beginning to see a trend with a patient that they're visiting the emergency room a lot, go a little bit past just those standard questions on that TOC template. Find out maybe why. I will tell you that one of the charts that I looked at in reviewing this data had several visits. When I opened up that patient's record and tried to find out what was going on, they certainly had a lot of issues. This particular patient happened not to be a Medicare patient, but had frequent visits to the emergency room because of a cardiac condition. And what I saw was that we were making contact, attempting to make contact, but probably our last 8 TOC calls ended up with we were unable to contact the patient. The patient did not answer their phone, and we were not able to reach them directly. So if you're running into this issue in your practice, I'd like for you to consider sending a letter to the patient and requesting them to call you back and discuss their ED visits. It's great. Part of our requirement is to attempt those calls. We're making those calls, but if the patient's been in that many times, we really need to figure out why. Try to see the patient. If you can't talk with them by phone, see if you can meet with them if possible. One of the things we want to try to figure out is, what are those social determinant factors that may be impacting that ER utilization? Are there medication needs? Sometimes we hear from patients, if I go to the emergency room, I don't have to make a copay, but if I come to the office, I have to make a copay. So they see it as less expensive to them, but we all know that it really costs more, and so we want to be able to look at that. We want to begin to also let them know how can they access that the primary care after hours. And in the meeting recently that Dr. Callery and I were in, one of the clinics was sharing a best practice of how they try to provide education on cost of what an ED versus an office visit really costs the patient. And we'll try to get more information on that, but I'm going to put this in the tactics of educating patients on what the actual cost of the ED is and how it's not a cost-effective approach for urgent care or a direct office visit. The other thing is, you're getting a patient that's having 17, 18, 20 ED visits. I want you to consider making a referral to Cindy in high-risk case management in our area. Review that record with her. Let's see if we can figure out what's going on. There's a good process we have for that, and we might be able to dig into some reasons why and how we can begin to address those. We might have to bring in social services on that. And then for those patients that need a lot of extra support, go ahead and put them on your longitudinal list. Develop a care plan for them, manage their symptoms, provide them some education support on their illness or how to manage stress, and give them some support on that. I'm going to jump out of here real quick, and we're going to go take a look at the UPC CPC Connect site and just take a look at this. So you can see here, this is where, I'll zoom up a little bit. This is our site. We're going to go all the way down here to find that new report I was talking about. Here's the ED summary report. We're going to click into that report. It's going to give us a lot of information on our patients. Okay, so what I've done is I've clicked into that report. I've actually de-identified a couple of patients for us to look at. I just used South Tulsa Family Practice as an example. You'll see some of those graphs down here. You'll find your clinic name. Click on your clinic tab, and it's going to bring you up to the patient. You're going to see the patient's name and information here. You're also going to see the number of times that they were in the emergency room. And then it may tell you if they had any admissions off of that visit or not. But you can see this particular clinic only had 2 patients, and they each had 4 visits, and their primary care provider is the same. So you want to go in and do a review of those patients and try to see if you can figure out why. And maybe those admissions or those ED visits all happened in a cluster around a particular episodic illness, or maybe this patient has some chronic illnesses and flare-ups keep occurring, whether it's COPD or CHF. So that's how I want you to begin to use these reports. Again, it's on the UPC Workplace Connect site, and we can get right back into our PowerPoint presentation and kind of wrap this thing up for the day. Okay, so we're back on the screen. We kind of reviewed that data. We're going to click into your clinic site and get more information on our patients. In doing some research on some things, we have, if you guys remember from our in-person learning sessions, we have some CPC Connect resources that are available to us. We went out and found this this effort that Cascade East in Klamath Falls, Oregon, is doing to try to help lower their ED utilization rate. They're doing some transition care calls like we are. The one thing that I did highlight in this first bullet point was that they're providing education regarding the clinic access and availability of a triage nurse during office hours. Now, I will tell you that we're looking at how do we expand that maybe past office hours. Each of your clinics has a process for reaching providers after hours, so you need to make sure you understand that process for your clinic and how to do that. The other thing that they do is they have nurses that contact the patient during business hours, and they have the authority to book and overbook patients and provider slots depending on their need. They have done a number of other things you can see on that poster board that they did, and they have seen some decline in their ED utilization. I will attach that poster board information for you, and you can have that in a better readable format. So let's wrap this up. So the quality metric follow-up for next week, you will be meeting as your clinic and discussing your quality metric for basically the final fourth quarter, or the fourth week meeting in February. Just report on your progress. Each of you selected something different. Some of you had A1C, some of you had blood pressure measures, some of you had colon and breast cancer and PAP measures, cervical cancer screening. By next week, we should have the updates done and up and running, but let me just give you an update on the blood pressure measure that we've been paying attention to for the past couple of weeks. Just remember, the diagnosis of hypertension has to be on the problem list, and in all the hundreds of charts reviewed, we did see that missing on several records. There needs to be a data onset there. It would be helpful if you could have the date that the patient, probably the earliest date that you know of the patient had the diagnosis of hypertension. If you don't have a date entered there, Epic will default it to today's date. And right now we're in an okay place for meeting the 2019 measures. We did do some updates for 2018. We abstracted the data out to get the right date in. I think we're in a good spot, but just remember to put a date in for that problem list. And then just a rediscussion of the way the metric is counted across the country. This is not a UPC decision. This is a CMS requirement. It is the last blood pressure entered at an office visit, which could be a wellness visit, a transition care visit, but whatever the last blood pressure is for the year for that patient, could have been done in October, November, or December, might have been done in July. That will be the measure that will determine whether or not we meet that measure. There were some questions last week about, can we have the nurse follow up? You can have the nurse follow up, but at some point it needs to be a visit that counts for that measure. If your blood pressure is controlled on the next visit you schedule for that patient 3 to 6 months out, that'll be great. However, there is not a code submitted with that nurse visit that CMS will recognize. So they will only pick up that office visit code. Finally, the blood pressure measure update in Epic was delayed this week. And by Friday, in a couple of days, we should have those numbers, and you should see some good improvement in your metric there. Okay, let's wrap this up. We're going to try to start to include some wrap-ups on here. Use your third week template to document this webinar. Be sure to get your sign-in sheets completed. Document any action that you're going to have today based on this discussion. What are you going to do with that ED patient? That's what you're going to put in your minutes. Make sure the assignments are clear. Remember those SMART goals that we reviewed a couple of sessions ago. Has to be clear, has to be assigned, need to have a time frame for completing them. And then you're simply going to upload those minutes and the sign-in sheet into your CPC Plus Connect site. Really interested in seeing how we do. We'll track this measure for the remainder of the year to see if we can make an impact on that ED utilization. Thank you guys very much. Have a great Wednesday.